So imagine a patient comes into your clinic, right? She's a 48-year-old woman, and she is just drinking water constantly.
Like unquenchable thirst.
Exactly. Her main complaint is this extreme thirst, and she is urinating more than 3 liters a day. You hear thirst and frequent urination, and your mind immediately jumps to the most obvious culprit, right?
Diabetes mellitus. It's the classic presentation.
Right. So you check her blood sugar, but it's completely normal.
Which is where things get interesting.
Yeah, you dig deeper and you find the actual cause. She's producing these massive amounts of urine because she has neurogenic diabetes insipidus. And that was triggered by a breast cancer metastasis that literally seeded itself directly into hypothalamus.
Wow. It's a really profound reminder that the human body doesn't always play by the simple rules we try to impose on it.
All right.
I mean, we like our diagnoses to be binary,
Right.
like a broken bone on an X-ray. But internal medicine is this interconnected web where a symptom in one system is frequently just an alarm bell for a crisis in another entirely different system.
Absolutely. Well, welcome to another deep dive. Today, we are speaking directly to you, the medical student, the young professional, or the dedicated lifelong learner who's just looking to sharpen your diagnostic reasoning.
And our mission today is to explore some key excerpts from a foundational text, which is 100 Cases in Clinical Medicine, the 3rd edition.
Yeah, we're basically treating this deep dive like a clinical ward round. We are focusing purely on problem-based learning.
Right, because the core philosophy of this text argues that superficial factual accumulation, just memorizing lists of symptoms from a textbook is vastly inferior to anchoring your knowledge to a real clinical presentation.
Because it's just harder to remember abstract lists.
Exactly. You are far more likely to remember a really complex physiological pathway when you attach it to the story of a real patient in distress. I mean, human context is the ultimate anchor for memory.
That makes total sense. So we're going to begin with the absolute bread and butter of clinical practice, which is redefining the common presentation.
Right, the stuff you see every day.
Yeah. You're on the ward and you see patients with everyday complaints. A persistent cough, a stomachache. And the source material flips the script on what these symptoms actually mean when you look past the obvious.
Which is critical because cognitive bias so often tempts us to just stop at the first organ system we look at.
Yeah, totally. So take case 4, right? A patient has persistent dry cough. You run a chest x-ray and it comes back completely normal. The text highlights the 3 most common causes for this specific clinical picture.
And they might surprise some people.
Right. Asthma makes up about 50% of cases. Then sinusitis or postnasal drip accounts for 25%, and reflux esophagitis sits at 20%.
But notice what is conspicuously absent from the very top of that list.
Yeah, bacterial infection.
Exactly. A persistent dry cough with a normal chest exam and a clear X-ray is incredibly unlikely to be caused by a bacterial infection.
So giving antibiotics is just pointless.
It's worse than pointless. The clinical pearl here is that reflexively prescribing antibiotics in this scenario is not just unhelpful. It actively exposes the patient to side effects for literally 0 therapeutic gain.
Right. I want to focus on that 50% number for asthma, though, because it feels counterintuitive based on how we're initially taught about the disease.
How so?
Well, I usually look at diagnosing a cough like troubleshooting a machine, right? You look under the hood at the engine and the lungs to find the problem. But sometimes the issue is actually a leak in the exhaust system, like gastroesophageal reflux, bringing acid up to irritate the airway.
That's a great analogy.
Thanks. But if the issue is the engine, if it's asthma, why isn't there any initial airflow obstruction? The text notes this patient's physical exam and initial spirometry might not show that classic wheeze or, a drop in lung function.
Right, it doesn't fit the classic picture.
So how can it be asthma without the physical obstruction?
Well, what you're describing is a phenomenon called cough variant asthma. We really have to view the pathophysiology of asthma not just as structural narrowing, but fundamentally as bronchial hyperresponsiveness.
Okay, so it's overreacting.
Precisely. In these specific patients, the inflammatory cascade in the airways is triggered by stimuli, like cold air or exercise. This inflammation stimulates the cough receptors that are located right in the airway epithelium.
Oh, okay.
Yeah, the crucial detail here is that the sensory alarm goes off before the smooth muscle constriction and the mucus production becomes severe enough to cause a measurable drop in FEV1, your forced expiratory volume.
Okay, so the alarm bells are ringing, triggering the cough reflex, but the doors to the airway haven't physically slammed shut yet.
That is exactly it. The hyperresponsiveness is present, but the gross mechanical obstruction is lagging behind.
Fascinating.
And because the inflammation is already present, empiric treatment with an inhaled corticosteroid and a short-acting beta agonist often serves as both a diagnostic tool and a therapy. Like if the cough resolves with the inhaler, boom, the diagnosis is confirmed.
Wow, that's such a clean way to diagnose it.
Yeah.
All right, let's move from the chest down to the GI tract and look at the acute abdomen. The text gives us case 5, which is acute cholecystitis, and contrasts it with case 41, acute pancreatitis.
Both very painful.
Very. Both patients present with severe, agonizing upper abdominal pain. So how are we differentiating these on our ward round?
It really comes down to pinpointing the exact mechanical failure and its anatomical location. So in acute cholecystitis, a gallstone typically becomes impacted in the cystic duct.
Which blocks everything out.
Right, it creates a closed loop obstruction. The gallbladder just continues to secrete mucus, internal pressure builds rapidly, and the wall becomes highly inflamed. This localized inflammation then physically irritates the overlying parietal peritoneum.
Which gives us a very specific clinical sign when we examine the patient,
Right. Yes, a positive Murphy sign.
Right.
When you ask the patient to take a deep breath in while you deeply palpate the right upper quadrant, the diaphragm moves downward, pushing that inflamed gallbladder directly into your hand.
Ouch.
Yeah, the sudden spike in pain causes the patient to abruptly catch their breath, and you'll usually see accompanying tachycardia and fever. But pancreatitis presents a completely different anatomical challenge.
Right, because the pain in pancreatitis often radiates straight through to the back.
Yeah.
And the patient is usually vomiting relentlessly.
Exactly. In pancreatitis, the inflammatory process is retroperitoneal. It's sitting behind the peritoneal cavity. So because of this deeper location, the diagnostic key isn't isolated to physical palpation. You have to rely on serum amylase or lipase levels.
Because the enzymes are leaking.
Right. The pancreatic acinar cells are damaged, and these digestive enzymes leak directly from the inflamed pancreas into the systemic circulation.
Wow. So the physical location of the inflammation, whether it's contained within a sac in the right upper quadrant or leaking digestive enzymes into the retroperitoneal space, changes everything about how we diagnose it.
Completely.
And speaking of things leaking into spaces where they don't belong, that systemic ripple effect doesn't just happen with organic disease, it happens with our treatments too.
Yes, the iatrogenic pitfalls.
Exactly. This brings us to the cases outlined in the text, where the prescribed cure inadvertently causes a new crisis.
These cases are sobering, honestly. They demand a really high level of vigilance. Like case 42, which details a 62-year-old woman who undergoes a right hemicolectomy for colon cancer.
Okay.
5 days post-operation, she spikes a fever. The surgical team administers intravenous gentamicin, but very shortly after, her urine output just plummets to 15 milliliters an hour. Her blood pressure drops, and she enters acute renal failure.
Oh, wow.
Yeah. The text identifies this as a dangerous compounding of intra-abdominal sepsis from an anastomotic leak, combined with the gentamicin.
The physiological storm there is intense. I mean, first, the anastomotic leak means the surgical connection in the bowel has failed, right?
Exactly.
So it's leaking highly infectious contents into the abdominal cavity. This triggers systemic sepsis. The body's inflammatory response leads to profound vasodilation, causing a massive drop in effective circulating blood volume.
So the kidneys are immediately underperfused and ischemic.
They are starved of oxygen and struggling to maintain filtration. And into this ischemic environment, we introduce gentamicin.
Which is a heavy hitter.
Yeah. Aminoglycosides are powerful weapons against the gram-negative bacteria swarming in that leak, but they are notoriously nephrotoxic. They accumulate directly in the cells of the proximal tubule in the kidney, causing acute tubular necrosis.
It's the perfect storm. The kidney, which is already suffering from hypotensive shock, is now being directly poisoned at the cellular level by the rescue medication.
It's terrifying. And the text highlights a critical blind spot many clinicians have regarding the monitoring of these specific drugs. You have to monitor trough levels, the concentration of the drug remaining in the blood, just before the next dose is administered.
Right, and the assumption is often that a rising trough level will warn you before the kidney is damaged.
But it doesn't.
The physiological reality is the exact inverse. The drug damages the kidney's delicate filtration system first. As the glomerular filtration rate, or GFR, begins to fall, the kidney loses its ability to clear the gentamicin efficiently.
Wait, really? So it's because the kidney can no longer clear the drug that the trough level in the blood begins to rise?
Exactly. The rising trough level is a lagging indicator. By the time the blood test shows a high concentration, the GFR has already dropped, and the damage to the proximal tubules is well underway.
Wow, that is a huge pitfall. And we see a similarly destructive ripple effect with antibiotics in the gut in case 23, right?
Yes, the care home case.
Yeah, a 74-year-old woman in a care home develops acute diarrhea while being treated with intravenous cefuroxime and a daily proton pump inhibitor, lansoprazole.
Which is the textbook presentation of a Clostridium difficile infection.
Yeah. I look at broad-spectrum antibiotics like cefuroxime,
Yeah.
sort of like sending a heavily armed SWAT team into a city to eliminate a small group of criminals. They accomplish the mission, but they accidentally destroy the city's infrastructure, the healthy, protective gut bacteria in the crossfire.
That is exactly what happens.
But my question is the cefuroxime causing direct chemical damage to the gut wall, or is it purely the environmental vacuum it leaves behind?
It is entirely about the environmental vacuum. You have to remember, the human gut is a fiercely competitive microscopic ecosystem.
Right.
A broad-spectrum cephalosporin wipes out the normal, healthy flora that keeps opportunistic pathogens in check. C. diff often exists harmlessly in very small numbers in the gut, or, it's picked up from surfaces in the hospital environment.
It's just waiting for an opening.
Oh, exactly. Once its bacterial competitors are eradicated, C. diff proliferates wildly. And as it multiplies, it begins secreting toxin A and toxin B. These toxins bind to the colonic epithelial cells, triggering massive inflammation, fluid secretion, and mucosal damage.
Which manifests as severe diarrhea.
Exactly.
And the proton pump inhibitor, she's taking the lansoprazole that plays a crucial role in lowering her defenses before the bacteria even reaches the colon.
Oh, absolutely. Gastric acid is a primary, non-specific immune defense. The highly acidic environment of the stomach neutralizes most ingested pathogens.
But PPIs suppress that acid.
Right. They intentionally suppress acid production. This effectively lowers the biological drawbridge, allowing C. diff spores to survive transit through the stomach completely unscathed and reach the colon.
That's a bad combination.
It is. When you combine that compromised initial defense with an antibiotic-induced vacuum in the gut, especially in a patient over the age of 65, the risk of severe infection just skyrockets.
Wow. It's so interconnected. We just saw how a drug acting in the gut or the blood can destroy the kidneys. That systemic ripple effect doesn't just happen with medications. It's really a fundamental characteristic of chronic disease, too.
Definitely.
Seemingly localized, isolated symptoms are very often just the tip of a much larger systemic iceberg. Let's look at case 45. A 45-year-old woman presents with pain in her right forearm that primarily wakes her up at night.
Classic symptom.
Right. The mechanical diagnosis is carpal tunnel syndrome, a physical compression of the median nerve at the wrist. It sounds like a localized structural issue. But the text connects this isolated nerve pain to a complex web of systemic conditions. She suffers from rheumatoid arthritis, she has a family history of hypothyroidism, and she's obese.
Right, so the mechanical compression of the median nerve tells us what is happening, but the systemic conditions explain why.
Exactly.
Rheumatoid arthritis is a systemic autoimmune condition that causes tenosynovitis, which is chronic inflammation of the tendon sheaths. These inflamed sheaths physically swell and crowd that really tight space of the carpal tunnel.
So there's physically less room for the nerve.
Exactly. Furthermore, hypothyroidism can cause myxedema, which involves the deposition of mucopolysaccharides in the tissues. These molecules draw in and trap water, causing widespread tissue swelling that further compresses the nerve.
And then the obesity compounds all of this.
Right, by increasing overall tissue mass and fluid retention in the extremities.
So just treating the localized pain with a wrist splint completely ignores the underlying pathology. A clinician has to actively manage the rheumatoid arthritis, evaluate her thyroid-stimulating hormone levels, and address the metabolic impact of her weight.
Treating a local symptom without investigating the systemic driver is just a temporary patch. It's not a medical solution.
This principle applies so brilliantly to case 59 too, which features a diagnostic connection that requires a deep understanding of human physiology.
This is a great case.
Yeah, a 52-year-old businessman is found to have asymptomatic microscopic blood in his urine during routine medical exam. There's no pain, no frequency, no obvious trauma. Now, if I see blood in the urine, my immediate thought process goes to a localized plumbing issue within the urinary tract.
Like a small tumor in the bladder or a kidney stone.
Right, or prostatic hyperplasia.
Yeah.
But the text directly links this isolated microscopic hematuria to his history of alcoholic liver disease. Mechanistically, how does liver damage from chronic alcohol consumption dictate what the kidneys filter into the urine?
It's all about clearance. The patient in this case has IgA nephropathy, which is actually the most prevalent cause of glomerulonephritis in the developed world.
Okay.
It's a condition defined by the abnormal deposition of immunoglobulin A, an antibody produced by the immune system directly into the mesangium, which is the central stalk of the kidney's filtering units.
Right. And the text notes that this patient drinks roughly 35 units of alcohol a week, and his lab results show an elevated gamma-glutamyl transpeptidase, or GGT.
Yes. GGT is a liver enzyme that is exceptionally sensitive to alcohol-induced damage. The liver isn't just a metabolic organ, it's a vital part of the immune system's waste management.
So it cleans up the immune complexes.
Exactly. It's responsible for clearing various immune complexes, including circulating IgA from the bloodstream. Chronic, heavy alcohol use damages the hepatic cells and drastically impairs the liver's ability to clear these complexes.
Ah. Because the liver isn't filtering them out, the IgA complexes just build up in the systemic circulation.
They accumulate in the blood, and as that blood passes through the kidneys, the excess IgA complexes get physically trapped and deposited in the glomerular filters.
Wow.
This abnormal deposition triggers a localized inflammatory cascade in the kidney, damaging the delicate blood vessels and allowing microscopic amounts of red blood cells to leak into the urine.
So the urinary plumbing is leaking because the body's primary filtration plant, the liver, is failing to do its job upstream.
That's a perfect way to put it.
And the source text uses this presentation to provide a really crucial triage rule for medical students evaluating isolated hematuria.
Yes, it's a fundamental division of labor in diagnostic medicine. If a patient presents with isolated, painless hematuria and they're under the age of 50, standard practice dictates referring them to a nephrologist first.
Okay, because you're looking for kidney disease.
Right. The goal is to investigate medical kidney diseases, such as glomerular pathologies like the IgA nephropathy we just discussed. However, if the patient is over the age of 50, the referral goes immediately to a urologist.
And that hard line at age 50 is based purely on shifting statistical probabilities, right?
Yeah.
Over 50, the risk that the bleeding is originating from a malignancy, specifically bladder cancer or prostatic lesions, rises exponentially.
Exponential.
So a clinician must definitively rule out cancer with a cystoscopy before spending time investigating complex autoimmune kidney diseases. Diagnostic vigilance requires knowing when to look for the common conditions and when to assume the worst. We are taught the famous medical aphorism: when you hear hoofbeats, think horses, not zebras.
But missing a zebra masquerading as a horse can have catastrophic consequences.
Absolutely. We see this clearly in case 67. A 48-year-old woman who is physically active and regularly plays tennis presents with a 3-month history of back pain in the mid-thoracic region.
A muscular strain is a very common horse in an active patient.
Right, but a subsequent x-ray reveals a collapsed T6 vertebra, and a thorough physical examination, which had been previously omitted, reveals a firm mass in her breast. The back pain was actually caused by metastatic breast cancer destroying her spinal column.
Which is horrifying, but it highlights why you have to be thorough.
Right. And we saw another zebra with our very first patient in the introduction, the woman with extreme thirst and polyuria. She is voiding huge volumes, and the common assumption is diabetes mellitus.
The horse.
Exactly. But when her blood sugar is normal, the clinician has to pivot to neurogenic diabetes insipidus. But how does a tumor in the brain physically force the kidneys to dump 3 liters of water a day?
Well, the hypothalamus is responsible for producing arginine vasopressin, or AVP, which is more commonly known as antidiuretic hormone.
Okay.
AVP is the chemical messenger that travels down to the kidneys and commands them to reabsorb water back into the bloodstream. The metastatic tumor physically infiltrates and destroys the specific neurons in the hypothalamus responsible for synthesizing AVP.
Oh, wow.
So without that constant hormonal signal instructing the kidneys to hold on to fluid, the renal tubules simply let the water pass through continuously, resulting in massive dilute urine output.
The text continually emphasizes the necessity of repeating previously normal investigations if a patient's symptoms persist. It's like, instead of thinking of a diagnosis as a single snapshot, think of it like monitoring a seismic fault line.
I like that.
Right. A minor tremor on the instrument isn't immediate proof of a massive earthquake, but if the needles keep twitching and the ground keeps shaking, you don't just turn off the monitor and walk away, you dig deeper into the crust.
Exactly.
But practically, how does a clinician avoid over-investigating every minor complaint?
By heavily relying on clinical red flags to stratify risk. So in the case of the backache, the red flag is the anatomical location. Pain localized to the thoracic vertebrae in a patient over the age of 40 must always raise a high index of suspicion for bony metastases.
Because the thoracic spine is structurally different.
Right. It's structurally rigid because it's anchored by the rib cage. It does not endure the same mechanical wear and tear that causes degenerative disc disease in the highly mobile cervical or lumbar spine. So spontaneous, persistent pain in the thoracic region is a massive red flag.
Good to know. And with a polyuria case, the red flag is the strict clinical definition of the volume, right?
Yes. True polyuria is strictly defined as an absolute urine output greater than 3 liters in a 24-hour period. A clinician must distinguish this from urinary frequency or nocturia.
So frequent urination doesn't necessarily mean high volume.
Exactly. Patients with an enlarged prostate or a urinary tract infection will urinate frequently, but in very small volumes. The total daily output is actually normal. If a patient is passing massive total volumes of fluid and diabetes mellitus is ruled out, you have a physiological crisis. You must investigate the pituitary hypothalamic axis. You have to look for the zebra.
Right. Well, as promised for our listeners, we're going to close-out this deep dive with a rapid-fire review exercise to solidify the diagnostic frameworks we've covered today.
Let's do it.
All right, here's the prompt. You're evaluating a 56-year-old woman presenting with sudden right upper quadrant pain, a fever, and jaundice. Her blood tests return showing a preferential elevation of alkaline phosphatase and gamma-glutamyl transpeptidase. Meanwhile, her cellular liver enzymes, specifically ALT or alanine aminotransferase, are only slightly raised above baseline. 2 questions for you. Based on this presentation, what specific clinical sign would you expect to elicit on physical examination? And what physiological state does this enzyme pattern suggest?
Well, based on our earlier breakdown of the acute abdomen, the localized right upper quadrant pain should immediately prompt the listener to test for a positive Murphy's sign, inducing an inspiratory arrest upon deep palpation as the inflamed gallbladder meets the clinician's hand.
Right.
And regarding the laboratory results, the preferential rise in alkaline phosphatase and GGT, combined with only a mild elevation in alanine aminotransferase, is the classic biochemical signature of an obstructive jaundice.
So like a blockage.
Exactly. It indicates that the biliary tree is physically blocked, most likely, by a gallstone migrating into the common bile duct. If the primary issue were hepatocellular damage, such as viral hepatitis, the ALT levels would be massively elevated as the liver cells themselves ruptured.
Taking the time to understand the physiological why behind an elevated lab value just completely transforms how you interpret clinical data.
It really does. And before we finish, consider this final thought. The central thesis of 100 Cases in Clinical Medicine is that witnessing a patient's physical and emotional presentation cements knowledge in a way no data set ever can.
Absolutely.
Look at case 70, where a young woman presents with total paralysis of her left leg, yet she displays what the French term la belle indifference, a baffling, cheerful lack of concern regarding her profound disability.
That is so strange.
It is. But that subtle psychological mismatch between the symptom and the emotional response is the diagnostic key to identifying a dissociative or conversion disorder.
And a lab printout cannot quantify la belle indifference.
Exactly. As modern medicine shifts heavily toward remote telehealth appointments, asynchronous messaging, and AI-driven diagnostic algorithms, a critical question emerges for the next generation of practitioners. How will future clinicians develop the intuitive human pattern recognition required to spot an inappropriate smile or read the tension in a room?
Right, if you aren't there.
If the clinician is no longer sharing physical space with the patient, what essential diagnostic clues will be lost to the void of a screen?
You can aggregate all the biomarker data in the world, but if you strip away the human context, you risk missing the patient entirely. Thank you for joining us on this deep dive into clinical reasoning. Take these physiological frameworks and apply them to your daily practice. Until next time.